Thank you, Herman, and thank you. It's an incredible pleasure to be here in Austria with the Fulbright program, and thank you for the organization and the chance to just be here. It's fantastic. So my name is Dave Larsen. I'm at Syracuse University, obviously, and talk a little bit about systems of infectious disease surveillance. So COVID-19, do you remember where you were when you first learned about it? I was in Kenya, and I was working on some malaria programs. So my career has primarily focused in sub-Saharan Africa prior to COVID and mosquito-borne disease. And I was watching this as a respiratory transmitted pathogen. I'm thinking, what do I do? What can I help? Or how could I help? I don't know anything about respiratory pathogens. And then I started to see challenges in infectious disease surveillance. And so that's where I stepped in, and that's what I've done my entire career is infectious disease surveillance. So let's compare two pandemics here. The first, COVID-19, obviously there. It was declared a pandemic in March 12th, maybe 11th of 2020. The second is Zika. Zika was never officially declared a pandemic, but it fits the criteria. So COVID-19, obviously a respiratory transmitted disease. Zika is a mosquito-borne disease, and it causes microcephaly when it infects pregnant women. All emerging diseases, they start out with unexpected clusters. So something happens that is out of the ordinary. With COVID-19, the doctors in Wuhan, China, they started to see a lot of pneumonia patients that were unexpected. So there's a baseline level of pneumonia, so you see people with pneumonia throughout the year. That could go up with influenza season. But here they're seeing a cluster of patients with similar symptoms. They think, what is going on? With Zika, it was an OBGYN who started to see lots of children born with microcephaly. And it was unexpected. So these statistical anomalies are the very first indication that something is wrong. Then you start to figure out, well, what's the mode of transmission? So we know COVID-19 is airborne. There was a huge debate about what airborne actually means, but it is airborne. Zika is a mosquito-borne virus. This is the Aedes, I think it's an albopictus actually, but the Asian tiger mosquito that spreads Zika. And these have huge implications for the way that we control infectious diseases. So epidemiologists, we think about infectious diseases based on their mode of transmission, because that then tells us how we should control them. So who's at risk of Zika? This is a risk map probability from 0 in the blue to 1 of finding the mosquitoes that are capable of transmitting Zika. And it's two specific mosquitoes. Out of hundreds of thousands of species of mosquitoes, there's two that transmit Zika, the Aedes aegypti and the Aedes albopictus. And so these dark red areas are where you're most likely to find Aedes aegypti or Aedes albopictus. These blue areas are where we do not find them. And you'll notice here in Europe, where we are in Austria, there's no zero probability. Here in the United States, in the south, there's some, but up north, there's not. We can contrast, and this is basically a risk map of where you could get Zika, right? You're not going to get Zika here in Austria, but if you travel to Brazil or to Mozambique down here, you may get Zika. When we contrast that with COVID-19, COVID-19 being spread by humans, by respiratory systems, it basically follows flight patterns, right? And so once COVID-19 emerges, because of the way it transmits, then the entire globe becomes at risk, and we would expect it to spread based on these global flight paths. So these lines are how many, each line is a flight, an international flight. So you have ties between Europe and the United States, Europe and Asia, big clusters here within Asia. So the response to these two different pandemics is wildly different. COVID-19 could have been anywhere, could go anywhere, and so that required broad, generalized response. So we have to shut down everywhere. Zika, we understand where it's not, and so we can do more geographically precise responses. And there were some of these responses, right? If you remember the Olympics in Rio, some people pulled out, some high athletes, they pulled out because they didn't want to risk Zika. And that made sense given the geographic restriction of Zika transmission. So anybody know what movie these stills are from? Bonus points. Here's pub quiz. Yeah. Contagion. The movie where the celebrities die. So here's Matt Damon and Jude Law, and she was in Amelie. I forget her name. Right. So this is the story based on SARS-CoV. Who knows what SARS-CoV is? Not SARS-CoV-2, but SARS-CoV. So you realize that the 2, SARS-CoV-2 is the virus that causes COVID-19. That 2 is because it's the second sarbecovirus that's so similar to the first SARS-CoV. COVID-19 was so predictable that Hollywood wrote the script in 2011. And if you go back and you watch Contagion, it's actually quite accurate in terms of how it spread. And why is it accurate is because it's based upon the 2003 outbreak of SARS that happened in Eastern Asia. So we know that COVID-19 originated from a bat. This is a really early paper. It likely had an intermediate host. The pangolin was implicated. It's not so, the evidence doesn't support the pangolin transmission right now or passage right now. I was kind of disappointed because the pangolin is the most trafficked animal in the world. So I wanted to call this the revenge of the pangolin. But that's probably not the case. Probably went through some other animal and then came into humans. And these are the markets where it emerged. So all the evidence suggests that it emerged from a bat, just like SARS-CoV did in 2003, and just like MERS-CoV, another sarbecovirus, emerged in 2012. So SARS-CoV-2 is the third coronavirus that has emerged in the past 20 years. And then just like the pathways, these are the genetic relationships between the Wuhan cluster here and then how it spread to Europe and the United States. And it just spread right along global pathways as expected. So all of this could be predicted and was known by scientists, and all of it was being warned to the policymakers. In the United States, no president really had any concern at all for pandemic preparedness until President Obama. He started he added the pandemic preparedness to the health security person to the Inner Security Council. I forget what it's called. And then President Obama briefed the President Trump administration when they came in. But one of the characteristics of the President Trump administration was you're fired kind of thing. So by the time that COVID-19 emerged, not a single person that had been briefed on the pandemic response was actually still around, right? And we have an estimated 20 million global deaths in 2 years. There's more now. Long-term sequelae, we're still understanding that. There's a lot of, these studies take time. These take cohort studies. And so there's a lot of hypotheses and theories and a lot of concern. So, go back to my second question. Could we have had a better public health response if we had known more about it? So I think about this term health security. Who's heard of this term, health security? Yeah, our disease ecologist in the room for sure, right? So health security is this idea that our liberties, our freedoms, our humanity is dependent upon safety from health threats. And these health threats could be like radioactive, they could be environmental contaminants, and they could be infectious disease. And so our health security, our freedoms are dependent upon, one way to ensure our freedoms is by having improved infectious disease surveillance. And surveillance is the continuous monitoring and tracking of infectious disease trends so that public health can respond. And a good surveillance system has to first confirm that a community is safe, and second, alert a community to an increased risk. So if it's not safe, it has to say, look, something's going on, something's wrong. So how do we do that? Going too fast here. There we go. So traditional infectious disease surveillance relies on diagnostic tests. So people get sick, they go to the doctor, your data gets recorded, gets counted. There's something called a notifiable disease. So if you have influenza, your number gets counted and it gets sent up the chain to the local health department, to the national, either the Ministry of Health or the CDC. But with an emerging disease, this system breaks. It cannot keep up. So this is a bar chart from January 2020 through January 2021 of how many diagnostic tests for COVID-19 were done in the state of New York. So the virus emerged likely in October of 2019. That's why it's called COVID-19, because it emerged in 2019. The genetic sequence was released on New Year's Eve 2019. And by the end of January, there were reliable diagnostic tests using PCR. Incredible scientific achievement, right? But the first diagnostic tests in New York State were not done until March of 2020. So you have all of this spread without an understanding of where it is. And the only thing that indicates that we have a problem are mounting hospitalizations and rising deaths. And so we don't know who is at risk and who's not. New York State closed its schools on March 17th of 2020 when minimal diagnostics were being performed. So all the schools in the state. We could not, in my county in Onondaga, you could not even get a test unless you had a link to travel with China until mid-May of 2020, right? And then the heroic effort to scale up to almost 250,000 tests a day. What the system shows me is if we rely on traditional clinical surveillance systems, there's no way that we can keep up with infectious diseases. There's no way that we can know which communities have it and which don't. So we have to look at something better or something different. So we look at wastewater. Everybody poops. This universal means that we're not missing people who don't have access to healthcare. We're not missing people who aren't symptomatic. We're not missing people who may not want to go get a test, right? Logistically, in New York State, there's 600 treatment plants. And could we scale up to 600 tests per day? Now, this is all with the premise that I hope you understand, like COVID-19 can be found in wastewater. It correlates with infectious disease trends. It correlates with hospitalizations. We use it to forecast all of that. So logistically, if we design the system to continuously test wastewater for emerging threats, then we can alert the communities when the threat arrives instead of saying shut down because we don't know when the threat will get there. I'm going to skip some stuff because I want to jump to this. So the reason I got into this is because I worked on malaria elimination a lot. And elimination is when you get rid of a pathogen from a community and then you're free, basically. And in human society, we've eradicated 2 infectious diseases. Smallpox, anybody know the second? It's a bovine cattle disease. What is it?
I guess it's polio.
Polio is still around. It's called rinderpest. It's like cow measles, right? So we've eradicated 2 off the face of the earth. They are no longer at any risk anywhere off the face of the earth. But then for polio, we've eliminated transmission where I'm not that concerned about polio transmission. Even if I were unvaccinated, I would not be that concerned about polio transmission, right? So can we use our infectious disease surveillance systems to then say, all right, this community is free, they don't have COVID-19 or they don't have this or that, or not? So we use something called freedom from disease. If we get non-detection of our pathogen in wastewater or any infectious disease system, one of 2 things happened. Either the pathogen is absent from the community and it's free, or the wastewater surveillance missed the pathogen. Now, how do you prove the absence of something? You can't, right? That's a trick question. You can't prove the absence of something, but you can quantify the probability here that you missed the pathogen in the wastewater. So if you quantify this probability, then you can generate a confidence interval around how confident you are that this other is true. And this comes from veterinary science. Perhaps the biggest plug to study broadly is you get ideas from all sorts of areas. So with veterinary science, the end goal is to bring an animal that's safe to market. When you bring an animal to the market, you don't want that animal to then get infected with brucellosis or some other issue and come back to your herd and then kill your livelihood. So you have to make sure that it's safe, and then you have all these different inspections looking for clinical disease, butcher inspections, herd surveys, to all say that there's no disease in this area, no mad cow disease, no brucellosis. So you can actually export animals and export products from your farm. And all this infectious disease surveillance system. Now, it's been applied for years in veterinary science, and it's been hypothesized that it could work for human disease systems like measles and malaria, lymphatic filariasis, guinea worm, but it's never really been actually incorporated into ongoing operations until now. So here's our COVID work. I'll skip that. I can talk to you about COVID if you want. I'll go back here. So if we have two rural counties in New York, Cayuga and Cortland County. So every time we do not detect the pathogen in the wastewater, we get a probability that we missed it and a probability that it's not there. So this here on the left, this is Cayuga County and then Cortland County. On the y-axis goes from 0 to 1, 0 probability, 0 confidence that the virus is not there. This means we detected it in the wastewater. So we know the virus is circulating. Then we get a non-detection and we have maybe 20% confidence. And we detect again. And then we get about 7 or 8 consecutive non-detections. And so our confidence increases. It's just like flipping a coin, heads and tails, and you get consecutive heads. Our confidence increases with each non-detection. With each non-detection, our confidence goes up that there's no COVID-19 circulating in that county, in that community. And this is Cortland County, another small rural county. We started out not detecting it in May of 2020, and then we get consecutive non-detections. And so we get up to about 80% confident that there's no COVID-19. You think about in the summer of 2020, what were you doing in the summer of 2020? I was at home with my 4 kids and my wife. We were not visiting friends. We were not visiting playgrounds. We went to some state parks, right? But we were basically doing the flatten the curve campaign. But if I had 80% confidence that there was no COVID in my community, I might have been a little bit more relaxed. And then the public health response could have been more tailored to that situation. The messaging changes from don't be human, right? Don't see anybody, don't go anywhere, stay in your house, to maybe stay local, be careful, right? And it changes the whole dynamic for that. This here on the right is the incidence, the countywide daily COVID-19 cases. This is Cayuga County here. You get a little cluster in May, June, corresponding with detection in wastewater. And then you get these sporadic cases that are not linked. And I wish we had the genetic sequencing for these so we could show they're not linked. But based on the timing and the location of where these were not linked cases. They were imported once-offs that didn't transmit. And they just didn't have enough to show up in the wastewater. Here in Cortland County, no cases, right? We get a little cluster in mid-July, right? And our confidence goes to 0 at the same time, and then it cleans up, and we get confidence again. We have minimal cases until we get up to school opens up again and the university opens and it goes up. That's about time. Right. So then so my work during the pandemic was basically building the state's wastewater surveillance network. And right now we're in the process of handing that over to the Department of Health. And we hope it continues. One of the best things that happened for the system was a polio outbreak in New York State in 2022. So I got a phone call that they had a paralytic case of polio in Rockland County. So New York City is right here on this map, and this is Rockland County, right? And so some poor fellow got polio on his wedding night, got acute flaccid paralysis, and I don't know what's happened later. He went through rehab for sure. And they were able to link it back to infection, to vaccine-derived polio that's circulating in Israel, right? And then we started looking in the wastewater. And these darker dots are where we found it consistently. And so we knew it was here in Rockland. It was up here in, I think this is Orange County and then Sullivan County. Then a little bit, these are kind of fainted in New York State. But we apply those same, and here's the math, we apply those same principles where if we estimate the probability that we missed it, what's the probability that we missed the polio in the wastewater? We have the repeated number of non-detections that we can get a probability that that community is free from poliovirus. So there's some math behind this. What this allows for is what if we have routine surveillance? So we test vulnerable communities, high-risk areas, geographic diverse areas. We just do routine testing, and we continually confirm that there's no threat there. If we get a detection, either a paralytic polio case or detection in the wastewater, we scale up, right? And then if we get consecutive non-detections, we scale back down. And we're, in the polio response, we're in this non-detection phase. So 2022, we had a lot of detections in wastewater throughout downstate New York. And then 2023, we had minimal, if any. And then 2024, we haven't had any. So we've actually just scaled this all down. And it works for most everything. So one of the big things that shifted my understanding of infectious disease during COVID was this idea that we could find COVID-19 in the wastewater and use wastewater to track incidence or track transmission. That was a paradigm shift because I'm an epidemiologist. We classify diseases based on mode of transmission. And there's this, we call it environmental surveillance, where you routinely test the environment where the pathogen is to be found. So wastewater made sense for polio because it's fecal-oral transmitted. It makes sense for cholera, another waterborne disease. But here we have a respiratory pathogen that's then tracked in the wastewater. So that leads us to ask, well, what else can be tracked? And it's basically everything. These down here are the greatest burden of disease, right? HIV, influenza for sure can be found in wastewater. Tuberculosis can be found. Malaria is easily diagnosed in stool, so can likely be found in wastewater. Measles can be found in wastewater. Whooping cough, we don't know. And here's all the research prior to COVID on the different pathogens that have been found in wastewater. But the microbiologists that do these studies, we're not really talking to epidemiologists like myself. So that's part of the new collaboration, trying to build that forward. And I'll close with this slide, right? So our health security was breached in 2020. We were not prepared for the COVID-19 pandemic, despite clear understanding that that's how it would emerge, and it's just like a matter of time. And so I think about our preparation being really poor infectious disease surveillance systems. We have free infectious disease surveillance. People get sick, they go to the doctor, their number gets counted, and we rely on free. And free is only as good as free is. And so we have to invest in systems that actually track infectious disease as well. And a few things that would work for both Austria and the US, the systems are actually kind of similar. Wastewater surveillance is really important. That's what brought me to Austria on the Fulbright to work with the folks in Tyrol. Genetic sequencing needs to be ramped up. Historically, you went to the doctor to see if you had a bacterial infection or a viral infection, so you get antibiotics or not. You wouldn't go to the doctor to find out what pathogen you have. So we need to start sequencing more of incident fevers. Electronic health records that are linked between pharmacies and primary health care and hospitals. There's a reason why so much of the COVID research comes out of the UK and Scandinavia, is because they have electronic health records. They can quickly do epidemiological research. And Austria's challenged with this, just like the US, with a kind of a fractured health system. And then contact tracing core, it's almost criminal that it took us as long as we did. And in the US, we have these people called firefighters, and they have the cleanest trucks in the county because we pay them to sit around and be ready. And so what do they do with their time? They wash their trucks and they go to elementary schools. In public health, we don't have the same type of things for public health people, for contact tracers. If you're not busy, or basically if you're not overwhelmed, they'll cut the funding for that position, and then it's just chronically underfunded. So we have to rethink, how do we have infectious disease contact tracing that works and can be surged? And so the stuff I work on is over here, because all these are big problems. If I can get a pointer. I work on just the wastewater surveillance. And thank you.